Good morning. I am Michel Bourin, professor at University of Nantes, France, and editor-in-chief for the Archive of Depression and Anxiety. To make you familiar with the journal, Archive of Depression and Anxiety is an open access peer-reviewed international journal published by Pertext Publication Private Limited. The journal published novel updated research information in the branch of medicine which deals with disorder related to depression, mood, and anxiety disorder. It's providing a path for discovering new methods or new mechanisms for curing chronic disease and helps other healthcare professionals to find out most recent advances in all the relative area of depression, mood, anxiety disorder, and their management. Today I will speak about an important topic: post-stroke depression. In recent years, researchers have been interested in the biological and clinical post-stroke consequences. Thus, several types of personality or behavior change can occur after a stroke. They are frequent and relatively unknown, and therefore are unrecognized. These disorders include fatigue, attention and concentration disorder, reduction or loss of motivation, and initiative, emotional lability, hyperemotivity, depression, anxiety attacks, cognitive deterioration, or even dementia. I mainly will speak about mood disorder and depression. Mood disorder and sometimes present, which can induce a depression or conversely under euphoric states. More often, there is an hypermotivity, an emotional lability. People then complain of excessive expression of feelings, easy crying, for example. Other cases, relative of patients testify an emotional blunting, which means relative indifference to emotion, aggressive behaviors, an intolerance to frustration, and conversely, excessive tolerance of situations that previously considered inadmissible. Over the last 15 years, large-scale studies have attempted to specify the prevalence of post-stroke depression from studies conducted during initial hospitalization, during rehabilitation stays, but also after returning home. If the figures advanced vary from 15 to 65%, the synthesis of these studies leads us to consider that about a third of patients who presented a stroke developed a depression in the following year. In the systematic review starting from 51 studies published between 1977 and 2002, the estimated rate of depression after stroke was 33%. It should be noted that most of these studies excluded patients with aphasia or prior cognitive impairment, given the obvious diagnostic difficulties. The literature is not homogeneous with regard to the most at-risk period of onset of depression. A number of longitudinal studies suggest that the incidence was higher in the first months than in the rest of the first years. This early onset of depression may, by delaying rehabilitation, have a significant impact on the distance effect of the stroke. The risk of depression, once returned to active life, has been highlighted by other studies and corresponds to a relatively repeated verified by the practitioner in charge of the follow-up of stroke patients. A few studies have attempted to quantify the severity of depression within the DSM-5 criteria for major and minor depression. Their frequency appears to be approximately equivalent, approximately 15% of each of the two presentations. In addition, this is a close relationship between the presence of anxious symptomatology and the occurrence of depression after stroke. Finally, post-stroke depression also has close and yet poorly understood links to post-stroke fatigue. In 2008, the Cochrane Stroke Group rated 16 studies of treatment for post-stroke depression with drug benefit in all therapeutic classes, but at the cost of equally significant increase in reported side effects. The authors recommend great caution in the use of antidepressant treatment after stroke for fear of epileptic seizure, falls and confusion in these weakened patients. In conclusion, depression is frequent, but of minor severity. It compromises the functional prognosis and increases the risk of morbidity and mortality. Its specificity lies in a set of semiological characteristics, early onset after stroke, linked with certain encephalic localization. It should be sought especially at the early stage during regular interview with the family and before any change in the patient's psyche. Thank you very much for your attention.